How is Louisiana under your and Dr. Abraham's leadership tracking with the Maha agenda?
Well, I think we're at the forefront of it, really, thanks to Senator McMath and his Senate Bill 14, which I think it was 14, right?
Yes, it was.
So that was a great bill, and that was a bill that I would describe. And, we have these controversial topics that we talk about, but I mean, there's not that many people who say, I really want red dye number 40 to be in my drinks and M&Ms. There's not a lot of clamor. It's like it's a political issue with almost no one on the other side. I guess the company that wants to make the product, a tenth of a cent cheaper by not putting something natural in. But this is something that I was really surprised at. I guess I shouldn't be. And Secretary Kennedy explained it well in his speech. He said, we've given the CEOs of these companies the ability to go to their shareholders and say, we're going to have to increase our costs on this product a tenth of a penny because there's a public outcry against the way we're doing it.
Thank you, ladies and gentlemen, for joining us once again on the State of Freedom.
Welcome, everybody, to the State of Freedom. It is Tuesday, July 29th at 10 a.m. I'm Danielle Walker, along with my co-host, Chris Alexander. We are coming to you live on Voice of the People USA Radio and TV network, on Rumble, X, YouTube, and Facebook. And we have a real treat for you today. We are talking all things Maha with Louisiana's own Deputy Surgeon General, Dr. Wyche Coleman. Before we get into the Maha agenda, let me read the scripture of the day. It is Luke chapter 4, verses 22 to 24. And it says, everyone was impressed by how well Jesus spoke, in awe of the beautiful words of grace that came from his lips. But they were surprised at his presumption to speak as a prophet. So they said among themselves, Who does he think he is? This is Joseph's son, who grew up here in Nazareth. Jesus said to them, I suppose you'll quote me the proverb, Doctor, go and heal yourself before you try to heal others. And you'll say, work the miracles here in your hometown that we heard you did in Capernaum. But let me tell you, no prophet is welcomed or honored in his own hometown. And isn't it true that God places his gifting on people regardless of their station in life, regardless of their family and their geography? He was mocked for being from a small town, as if the creator of heaven and earth didn't make those who live in big cities and small towns, villages, and even as nomads. So this is a word of encouragement today for anyone who has stepped out in faith or is on the edge of stepping out on faith, because the Lord's called you to do something that seems bigger than you, that may attract mocking or misunderstanding from family, friends, and neighbors. If Jesus didn't escape mocking, criticism, and misunderstanding for following his calling, we won't either. We all have a choice to make, just as he did. Are we going to bow to the mocking words of men and live paralyzed and controlled by criticism? Are we going to step out in obedience and faith and live that life we read about in Hebrews chapter 10, verse 39, that says this, but we are certainly not those who are held back by fear and perish, but we are among those who have faith and experience true life. So be encouraged today. Take this as a charge to go out in faith and boldness to do what it is the Lord has put on your heart to do.
Danielle, it's our guest today, Dr. Wyche Coleman, is a perfect example of what you're talking about, stepping out of his comfort zone to go and become the Deputy Surgeon General, which was clearly a career shift for him and able to do that. Dr. Coleman, it's such a pleasure to have you on the State of Freedom for a little while this morning.
Yeah, thanks very much for having me, Danielle and Chris. Happy to be here.
Our pleasure.
Yeah, absolutely. Our pleasure. Since you've never been on the show before, Dr. Coleman, tell our listeners a little bit about your background and how you got to be where you are right now.
Well, I'm an ophthalmologist by trade. My day job is cataract and refractive surgery. And I never really saw myself being involved in public health. But obviously, the way that COVID played out sort of drafted a lot of people into the conversation that were on the sidelines before. I've been interested in politics for a long time. I was a big fan of Ron Paul when he was running for president back in 2008. I think it was 2012. And that sort of got me interested. Dr. Abraham and I have been flying friends for a long time. I've known him for many years before he ran for Congress. When we climbed Kilimanjaro in 2011, and he was actually talking about getting involved in politics, that he was somewhat dissatisfied with continuing to sit on the sidelines while things were going south, and that's what motivated him. So we had a lot of conversation about that then. I've not been involved other than peripherally, supporting candidates that I thought were good. But then COVID rolled around, and my office was closed down, the whole world was closed down. The government wanted to hold down and vaccinate every man, woman, and child. And I thought that is a lot of overreach. And I think that a lot of people woke up to that, but in Louisiana, I think that they could have gone a lot differently in Louisiana. We could have been a lot like California if it were not for our Attorney General. And I'd known Governor Landry for a while. We supported him when he ran for Congress. I always thought, he's one of the few politicians I've met that has the ability to talk about issues from a philosophic basis. And I've always appreciated that about him. And when he was in the AG's office, I think they would have taken people's medical license from deviating away from the narrative if he had not been in the AG's office to stop that. Yeah. My dad's a general practice doctor in the country. He was doing early treatment for COVID. He got some threatening letters at the time. The pharmacists wouldn't fill. Some pharmacists were threatened not to fill hydroxychloroquine, ivermectin for COVID, and he was just trying to keep people alive.
Yeah.
And anyhow, in the midst of all this, the Surgeon General in Florida, Joseph Ladapo, great guy, he was a very good influence on that state and a good spokesman. We started talking, Dr. Abraham and I started talking about the role of a Surgeon General in state healthcare. And it seems like we've had a little bit of a flawed process. We had a state health officer in Louisiana, but that wasn't at the top level of policy creations. Policy creation was typically generated by public health professionals, and it's on its way out the door. You had a doctor comment on those things. And Dr. Abraham and I both believe that it would be a better process if you had a doctor involved, especially a doctor that is practicing medicine at the top level of policy creation, that you probably have policy that makes more clinical sense and is more relevant to what's really going on, at the level of the street where the patient is actually being seen. Yeah. And, Ralph works in a rural part of Louisiana, sees Medicaid in a general practice clinic. He's an old school doctor. And so he was the perfect person for that job, having been a congressman previously as well. So him and Governor Landry got together, and we ended up getting a bill passed through the legislature unanimously to create the Office of Surgeon General. And I think he's really been a good influence on Louisiana during Governor Landry's administration.
Yeah. So your current position sounds like, Dr. Coleman, was born sort of organically out of your own observations, your own experience with regard to how LDH and the government generally responded to COVID and this mass push for vaccines, all of the lockdowns and everything else. And I've noticed that there's been a very significant shift under Dr. Abraham with regard to the policies of LDH and the Surgeon General, one of which is there is no longer, it used to be, you'd go down the street and every other sign would be pushing to get a vaccine of some sort, usually the COVID vaccine. I mean, the constant pressure to do that, you don't see that anymore. And also, it appears that Dr. Abraham and your office are trying to return medicine to the clinic, trying to return medicine to the doctor and giving the doctor primary authority and making these vaccine determinations on an individualized basis. And we certainly applaud that effort. Why is it so important that we change the policy generally with regard to these vaccines that we saw under John Bel Edwards?
Well, we get tangled up in vaccine debates and conversations a lot, more than I would like to, because I think that is a peripheral issue. That's a symptom of the underlying disease. And I think that the underlying disease is the philosophic approach to public health, that, we've been living under a collectivist ideology in public health in the United States for maybe like 50 years or something like that, maybe longer. And basically that approach says that we have a study that says if you do this intervention, it could be a vaccine, it could be whatever. It ends up being that a lot, so that ends up being the hot topic. But the principle is that we have a study and we say if we do this thing, then we're going to have this result in one study. and or maybe multiples. But we want the general idea there is that, well, now we're going to scale that to the entire population of the nation, and that we're going to end up with these very good results. Now, if we were having very good results in terms of, cost and outcomes in healthcare, then that would be one thing. Maybe those policies should be continued. I would argue philosophically they're flawed from the beginning, but the results are flawed too. So we've got the highest spend, and we've got some of the worst outcomes in the whole world. Some third world countries beat us in several important metrics. And then you have Louisiana that's basically at the bottom of that pool. And so what we can say from objective fact is what we are doing is certainly not working. And I think that you have the people who've been in charge for a long time who want to do more of the same. And what we say is to take the opposite approach, that maybe we should do something different. And the question then is what? And we both, Dr. Abraham and I, both still see patients. The Surgeon General, Deputy Surgeon General is by definition a part-time position. It is to be occupied by someone who is practicing medicine. So they still have a connection to the level of the patient. And the way that medicine is practiced in a public health perspective is very different than the way it's practiced when you're sitting in the room with a person, because you're always trying to give the maximum benefit to that individual. And so I think public health has sort of forgotten that. And they need to get back to the idea of keeping in mind that if we have maximum health for maximum individuals, then population health will improve. So I think the one-size-fits-all approach was flawed philosophically, but I think it's also had poor practical effects, and that we should take a different course. And that's where Dr. Abraham and I talk a lot about getting the third-party influence out of medicine, out of the medical decision-making, and leaving it back to doctors and patients to the greatest degree possible.
Yeah, I agree with you. And I love that idea. I visited China a number of years ago, and that's where this collectivist mindset really thrives. And it is to the detriment of every single individual to think about public health as one big blob. The public is made up of a bunch of individuals. So if we attack it, to your point, all as one with one hammer, we're never going to get the results that we want. And that's why as a state, but also as a nation, our philosophical grounding is in we the people being sovereigns. And that brings me to what I saw in the news yesterday, that the American Academy of Pediatrics came out pushing for the end of religious mandates, which to me seems like they must see the writing on the wall with RFK Jr. perhaps. And they fear that many people will end up using these religious mandates. I've used a religious mandate. I want to hear what you think about that, but also maybe I'll just share. I feel like exemptions for sovereigns is the most ridiculous thing you could possibly think about. The government just needs to get out of all of our decision making, in my view, for as far as it comes to any medical decision we make. I mean, I wouldn't be against banning mandates banning exemptions if it actually meant that the government would get out of my business.
Yeah, the whole question, well, the Academy of Pediatrics has gone totally crazy. They voted unanimously in 2003 to recommend gender affirming care for minors. The libertarian in me says, once you are of age of consent, do what you want. That's not anyone else's business, certainly the government. But we recognize that kids, we don't let them choose what they should have for dinner. We don't let them drink alcohol because we think that they're not old enough to make those decisions on their own. So the idea that we would then give them gender affirming care that's permanently life altering is not good. I think it's telling of how the Academy of Pediatrics has basically been hijacked. I think they were a good organization at one time, but in 2003, they voted unanimously for that. Now they come out and say, we don't want any exemptions. We want to hold you down and make you do something. I mean, that is completely undermining the doctor-patient relationship, which is where the decisions should be made. But I'm with you, Danielle. I think it's flawed that we have to have an exemption in the first place. And it's interesting, Benjamin Rush did some writing and reportedly petitioned James Madison to include in the Bill of Rights the medical freedom on the same plane as religious freedom. And Madison couldn't quite imagine a world where that would be necessary, but, Rush could see it. And I think that at the state level, one of the things that we could do is to protect in statute the idea of medical autonomy. You should not have to submit a religious exemption to not take a medical procedure or a medical product. It should just be, I'm not doing it.
Yeah, thank you. Have you heard of Dr. Jack Cruz? He used to be a
Yes.
neurosurgeon. He wrote the Health Bill of Rights for the country of El Salvador.
Yeah, I've seen some things about that, and I think that healthcare bill of rights is something that probably would be a good thing for America. These policies that are pushed by the Academy of Pediatrics to say we're going to remove all your exemptions, that would be okay in like China or the USSR, but this is America.
Yeah.
Who gives you the right? The right doesn't come. The right
Yeah.
doesn't come from the state. The right comes to the individual from God, and we give some of it to the state, but not much, and certainly not
Yes,
the ability to tell us what products we have to take.
exactly. In other words, as the Declaration of Independence says, in order to secure these rights, governments are instituted among men, not to create rights, not to grant rights. And one of those rights is autonomy over whether or not we choose to undergo any kind of medical procedure. Why do you think it is, Dr. Coleman, that the very simple notion that what a patient chooses to do with regard to his or her own medical care is a decision that should be made based upon strictly and solely the consultation with his doctor, and nobody else has any right to be involved in that? Why is that a controversial notion?
Well, because I think that they're losing some of the arguments on their merits. And now they're frantically trying to figure out how they can use force to continue to push the agenda that they want to push. It's probably a good sign that they're coming out with things like this, because I think they're showing their true colors. I think it's somewhat of a shame with the whole vaccine debate. And I've said for a long time, and Dr. Abraham and I have had some heated conversations with pediatricians, let me say, because they take from a vaccine policy standpoint, it is like religion. It is all or nothing. Not all of them, but certainly the mainstream, the Academy of Pediatrics, they say you either have to accept them all exactly as the CDC schedule says. Well, they don't like that anymore because Secretary Kennedy's, making that more sane. But they say you got to accept the schedule. It's all or it's nothing. And if you deviate one bit, you're out of the practice. Some will kick you out of their practice if you don't follow the schedule according to exactly how they put it out there. Well, there's no, individual decision making. There's no tailoring to the patient's circumstances in that case. But, what I would say to them is that this is a pretty simple fact, that as the schedule grows, so let's imagine that every vaccine is excellent and has the intended result and has zero side effect, no risk. We know that's not true. There is some risk. I think in some cases the benefits outweigh the risks, but that's the question that should be made on the individual basis. But just theoretically, as this schedule gets larger, as you add more and more and more and more, and then you present a parent with an all or nothing choice, proportional to the size of the schedule growth, more will choose nothing.
Yeah.
So, I think that there should be some effort to rank them on the basis of importance. I think that would be a good thing for doctors trying to give good advice. Dr. Abraham encounters this a lot more because he's in a general practice clinic. He's seeing parents with young kids that are trying to get some guidance. And, it would be nice to say, here's your top 5 or your top 10 or whatever, that, I think you could prioritize them pretty easy. Safety record, how long they've been around, do they prevent a deadly disease, and sort of go down the list from there. But as you grow the schedule, more people are going to say no. And then as that happens, the side that wants everyone to comply is going to become more frantic, trying to figure out new ways to make them comply. But I think that they should go back to an approach of freedom, just convince more folks.
Exactly. And, exactly convince people of the efficacy of it.
Meet the world's first living, full-spectrum, certified organic CBDA hemp extract. Ness's hemp oil was extracted from seed to bottle without chemicals, solvents, or heavy metals, and it surpasses world-class standards for purity. This pure and powerful CBDA has been proven to reduce aches and pains, ease mental tension, and promote better sleep. To get yours today, visit the Shop Our Partners page at freedomstate.us.
One of the things that I read about Dr. Abraham is that every decision that is made should be based on rigorous scientific study, objective, rigorous scientific study, the pros, the cons, the benefits. And that seems to be lost And there seems to be no convincing some of the groups that you're talking about, Dr. Coleman, about any of the potential adverse effects or harms of any vaccine. As you said, it's an all or nothing approach, and there just seems to be no objectivity. What is the source of what seems to be the willful blindness of these organizations to look at things in an objective way based upon real scientific evidence that RFK Jr. has talked about for so long, for instance? What's the obstacle there?
Well, I think that you've had at the level of the federal government corporate capture of the regulatory apparatus, and that's been driving a lot of this policy for a long time. You know, the goal is product sales. So
it's about money.
Well, I think that everything's about money, and so we've started to chip away at the doctor-patient relationship. But it's happened. It's not just in the vaccine question. I mean, you know, we have these. You know, we've had the governor's been pretty hard on PBMs lately, and I think rightfully so, because if your doctor prescribes you one medicine, your PBM may tell you can't have it, and so there's an example of another layer of third-party influence in the doctor-patient relationship. It goes on and on and on. And, you know, if I say someone needs an MRI and the insurance company says we're not going to approve it, well, they're just not going to get it. I mean, that's the hard truth in some cases. But, you know, all of that stuff represents third-party interference in the doctor-patient relationship. It is someone that it's someone who has an interest that is not primarily the patient's. I'm not saying they don't want the patient to get better, but you know, primarily their interest is the fiduciary responsibility to their shareholders. They need to make more money, and I'm not blaming them for that. If you're a CEO of an insurance company or a pharmaceutical company, that is what your job is. I don't blame them for doing their job. I would do the job too, but they also should not blame doctors and patients from wanting to get them out of that decision-making process. And I think that in the past, you know, public health is pretty hard leaned towards the insurance companies, the pharmaceutical companies, and they said, we're willing to toe the line for you. And I think that there's a shift, and Maha is a political representation of that shift, of saying what we'd like to do is just be a neutral organization to try to provide good advice, facilitate access to care, and then otherwise stay out of the way and let the doctors and patients just make the decisions that is best for the individuals and their families.
Do you foresee any moves to get the third parties out of the medical schools? Because it starts there.
I think that that's not had a lot of political movement yet, but I do think it's important because I think there is some capture there. What's the next step there? I don't know if I have a great answer for you. It's probably at the level of the LCME, that's the equivalent of ACGME for medical schools. They're the ones that regulate them. Yeah, I think that it would be good to have some, but it's a systemic problem.
Yeah.
It sort of starts at the top, but I think that we're really seeing a turn in the right direction. I think Secretary Kennedy is doing great. You know, we're real happy to see him there. We were proponents of him being in that position, wrote strongly in favor of it, have spoken publicly in favor of it. And, you know, we had a great lunch with him at Pennington a few weeks ago. And that was great. I had been wanting to meet him for a while. I'd not met him. And I think he was impressed by Louisiana. Did you see the governor's podcast afterwards?
I saw clips of it. I didn't watch the whole thing.
Yeah, well, he said, I don't want to be offensive, but, you know, Louisiana is not viewed by the rest of the nation as being the most enlightened state.
Yeah, we were talking about that earlier.
And then he said, but that was the best conversation I've had in 2 years of running for president and running the department. So that was very flattering. And I think that we're going to be on the forefront of the Maha movement. I think we have the opportunity in Louisiana to be the academic hub of the Maha movement because, you know, the Ivy League universities they may not be willing to look at these problems in an objective way. We've got the population, you know, we're at the bottom of healthcare outcomes. You've got Pennington, LSU, UL, the other university systems. There's a lot of academic horsepower here. So I think that we were well positioned to try to be at the forefront of understanding some of these problems better and doing a better job of correcting them and giving better advice to patients and doctors so they can make better decisions for the individuals.
Yeah, without forcing them or mandating any particular decision.
Look, if something's that good, the government don't have to make you do it.
Thank you.
Exactly. And that really is the acid test right there. If they have to force you to do it, how good is it? And what kind of messaging are you engaged in?
Yes.
Speaking of medical autonomy, Dr. Coleman, there's a law, as you know, in Louisiana now that allows, and this applies to any public or private schools, allows students through their parents to submit an exemption for any proposed vaccine, and it has to be taken at face value. There doesn't have to be an explanation given for why they are declining. They are simply declining. And that's what the law says in Louisiana right now. Unfortunately, during COVID, there were so many problems with it. It wasn't being enforced. It wasn't properly implemented. I'm asking you that to say this. There's also a law in Louisiana now that says if you're 18 or older, then you have the unabridged right to refuse to consent to any medical or surgical treatment as to your own person. That's what the law says in Louisiana regarding adults. Would your office consider implementing a rule that sort of clarifies that law, or a specific waiver that would be available to employees, for instance, to give to their employers pursuant to this law? I'm declining this particular medical procedure or whatever, and submitting to their employer the same way that students do, particularly minor students in Louisiana, just to give the law more teeth and you know, a more vigorous enforcement mechanism, perhaps.
Well, you're going to have the boss man on next Tuesday, so that's probably a good question for him. I don't want to get over my skis and answer on that, but certainly we're proponents. We've been pretty outspoken, when it comes to the flu shots. The flu shot is before COVID. The flu shot was really the test case. That was the thing that hospitals say are mandated. And we do run into a little bit of a conundrum where the federal government says to receive some of your federal money, you got to have a certain amount of flu shot uptake. And it's not like a one-to-one thing where if you don't get enough of your employees to take the flu shot, then you're going to definitely lose money. It's just one of the metrics. So you can achieve other metrics. So a hospital could have no one take a flu shot and they could still get the federal money. But I think they should have an alternative. I think it should all be voluntary. If they want you to mask in patient care areas, I think that the evidence for that is poor, but I don't have too much of a problem with it. It's not as much of a permanent thing. But as far as making a rule, I think that would probably be a question for Dr. Abraham. But what we need is the federal government to change their rules a little bit to allow more freedom on these fronts.
Yeah, but I'm talking, Dr. Coleman, I'm talking about issues that are not related to the federal government. I'm talking about general medical procedure, medical intervention, a vaccine or anything else, and just a general rule that a general waiver from Louisiana Department of Health, sort of codifying administratively this law in Louisiana that allows adults to refuse any medical procedure or intervention similar to the way they have with kids. So we will definitely ask Dr. Abraham about that and see what he says. But that's something that I think could be very helpful.
Well, certainly we agree philosophically with that idea. And then the technicality, the mechanism of making a rule and enforcing it, I probably have to look at that before I give you a straight up answer. Some of these things are better answered at the level of the legislature because then you have the force of political force behind them. I hate to get into the deal where you make rules. That's sort of what the last administration did. That was not in line with the will of the people. And I think the will of the people is pretty clear. They kind of, especially in Louisiana, seems like they want the government out of their lives.
Yeah, absolutely. We're just talking about a waiver that is directly consistent with current law. But I certainly understand your point on it.
And probably you run into some legal mechanism there to say, does that authority exist? And that's probably the first question. But philosophically, I could say we would support the idea that people have the right to accept or refuse any medical treatment.
Is your office, how has the public or how has the medical community generally responded to the shift in focus by Dr. Abraham regarding vaccines, the things that we've been talking about here?
Well, I think we've had a lot of positive response. We've had a little bit of negative response from the usual suspects the mainstream. Like we're a little bit of a departure from the mainstream. But I think that there is a silent majority out there of doctors because I don't think the doctors really want to be told what to do either. And it's sort of, some of the societies say we still want the government to tell us what to do when taking care of patients. And I'm like, that can't be popular amongst doctors. And I don't think it is. But I think that you've had a lot of people, speech was chilled during COVID. And believe it or not, there's still a lot of that hanging over people's heads. So we'll go and do talks and talk about some of these ideas of medical autonomy and getting collectivism out of medicine and removing the third party influence in the doctor or patient relationship. And there'll be a whole lot of people come up and say, or we've talked about, the COVID vaccine, which is a terrible, you can't go one day in clinic without seeing someone who's been injured by this thing. I can't believe that anyone's still taking it. But you have people who know that, and they are still sort of afraid to speak out. Once we go talk, they say, "Oh, thanks for saying that," and but I've not wanted to say anything about it. I've been thinking it for a long time. So I'm not sure if it's a majority, but it's a significant number. It seems like it may be, but then like in most things, you have it's like on Twitter, X as it is now. It's like 5% of total users make 99% of the conversation. You have vocal minorities on these subjects, but I think the majority of doctors likes the idea of the decision making being back in their hands.
Yeah.
Yeah.
And not just vocal minorities, but minorities that are somehow promoted from underneath. I do think that there's some funding mechanisms behind those voices, both on Twitter, because Twitter promotes people and gives them the followers and everything. But also, I think in the crowd that goes along with what Big Pharma's agenda is, I think there is some kind of funding mechanism there as well to amplify those voices.
It's always a mystery where the funding for some of these opposition voices come from, and it sort of makes it look like there's a huge majority out there. Right. But that's like these protests in cities. A great example I can think of just off the top of my head is when they had the protests in D.C. I don't know if y'all remember. Rand Paul was leaving the State of the Union speech.
I remember,
and almost got killed by a group of protesters. They surrounded him. I've got no ransom. He's the only ophthalmologist in Congress. We've been on a couple of cataract surgery trips together. He's a great guy. But he gets back to his hotel that night, which I can't remember which one it was, but it was a nice hotel. And the protesters were staying in the hotel.
Oh my gosh.
And the rooms were $700 a night. So the question was, who's paying for this?
Exactly.
The answer is someone. This is not organic. And I think that you can see that in some of these other debates too, that it looks like it's not organic. It is funded by someone trying to push an agenda.
Yeah, I agree with that.
Why is it, Dr. Coleman, that many parts of the establishment, even after everything we know about the COVID shot now, the harm that it's caused people, the damage it's caused people, the colossal misinformation about it for so long. Why is it that at least purportedly credible parts of the medical community and the medical establishment are still pushing the COVID shot? Why is that?
I think that if you, gave it to a lot of patients, gave it to your guys, advise your whole family to take it to your kids, it's pretty hard to wrap your mind around that being a wrong decision.
Yeah, it's hard to back down from.
Yeah.
I took 2 of them. It almost killed me. I had a resting heart rate of 160 after my second Pfizer dose. I took it early. Nobody coerced me. I was seeing patients. Luke Letlow died. He was about the same age as me, and he had just won the congressional race. I knew him well, and I was like, gosh, looks like it could be dangerous. I was the only member of my family who did. But it made me pretty sick. I think I'm okay now, but it took years to get over it. But I think that if you were someone who had given it to everyone in your family, it may be difficult for you to wrap your mind around the idea that was a bad decision. But
yeah, and I certainly understand that psychologically. Yeah, that how that could be very, very difficult to accept for sure. But we are thrilled that the focus of Dr. Abraham, your focus is to return primacy for medical care to the doctor and the patient. And it seems to me the underlying theme of your public health efforts is that. And my God, do we need it? Do we need it? It's so critically important. And I love Dr. Abraham's testimony. He testified, I believe, several months ago with regard to the general response to COVID. And, he was very candid about the mistakes that he felt were made. And all of those mistakes essentially stemmed from this collectivist mass one size fits all philosophy and approach of government, of big pharma, of big medicine, which your office is fighting against. And it's just so refreshing to see it.
Well, and I think, COVID was a great example of where when you let the doctors make decisions that you ended up with better results. And when they had to just follow it, just check the box,
Yeah.
that you ended up with worse results. And we got a lot of box checking in medicine nowadays where they say, you've got to do this and this is going to make someone healthier, counsel them on smoking, do whatever. Like every visit, you got to check this. I'm not sure that those things have a big impact on the ultimate result.
Yeah.
Well, Dr. Coleman, Dr. Coleman, back to Secretary Kennedy's visit. How is Louisiana under your and Dr. Abraham's leadership tracking with the Maha agenda?
Well, I think we're at the forefront of it, really, thanks to Senator McMath and his Senate Bill 14, which I think it was 14, right?
Yes, it was.
So that was a great bill, and that was a bill that I would describe. And, we have these controversial topics that we talk about, but I mean, there's not that many people who say, I really want red dye number 40 to be in my drinks and M&Ms. There's not a lot of clamor. It's a political issue with almost no one on the other side. I guess the company that wants to make the product, a tenth of a cent cheaper by not putting something natural in. But this is something that I was really surprised at. I guess I shouldn't be. And Secretary Kennedy explained it well in his speech. He said, we've given the CEOs of these companies the ability to go to their shareholders and say, we're going to have to increase our costs on this product a tenth of a penny because there's a public outcry against the way we're doing it. They were already doing it in Europe. You can get M&Ms in Europe, or sports drinks or whatever, Gatorade, and it doesn't have red dye number 40 in it or synthetic petroleum-based dyes. So it's not like they can't do it. They're already doing it, the same exact product. And, your M&Ms are like one shade lighter over there. So, Bill 14 listed a bunch of those synthetic dyes, some of the other petroleum-based preservatives, that just a laundry list of things that you can take one look at and say, that's probably not good for me to eat. And got it at least out of school lunches. So
Right.
It didn't get it out of everywhere, but it got out of school lunches. And I think that's a step in the right direction. There was a bill in Oklahoma that was very similar. And so now you have just two states that pass a bill, and now you have Kraft announced they're taking synthetic dyes out of their food products by 2027. You have a couple of other companies following suit. So I think this is a great example of how just a couple of states can make a big impact on the national stage. And the companies just do it voluntarily now.
It's probably a reflection of how many Louisiana citizens are eating M's too.
Well, M&Ms are pretty good. I might have had
We
some.
don't want to do away with the M&Ms, but get the junk out of it.
I was hoping they'd get the red dye out of it, but it hadn't happened yet. But it's coming soon, and I think that Bill 14 was like an obvious step in the right direction. And I think that, the Maha movement in general is a political recognition that what we have been doing is not working. We don't have very many movements in healthcare. I don't know when you can think of what the last movement was, a real political movement, but this is one. And I think it's a recognition at its core level that what we have been doing is not having the intended results and that we need to do something different. So I think that we have some very obvious things that we can do different. And that is, number one, to take the synthetically created, purposely put in poisons out of our food supply. As long as we allow them to poison us, they're going to continue to poison us. But as soon as we just push back a little bit, I don't think that these companies want to poison us. They're just trying to do whatever's the cheapest. And if you give them a little pushback, they'll do something that's slightly more expensive that is less harmful. So that's an obvious one. And then we've got a lot of things that we need some more data to make a good decision on. And, I think the other thing that's great is to getting the sugary drinks, the sodas out of the WIC program, because like 10% of all of WIC dollars are spent on soft drinks.
Yeah.
Sugary soft drinks. That's a lot. And you can make a big difference with small changes. There was a great study that they did at Pennington. They're at the forefront of research on chronic disease, metabolic health worldwide. It's really amazing what they're doing over there. But this was a fascinating study they did. They did it on pregnant women who were on food stamp programs, and that's how they get all their nutrition. And the prevailing wisdom was there's no way to buy good food on these programs. And so they took what was available on the WIC program. They built an app that said, this is your grocery list, and here's some recipes of foods that you can prepare using nothing but what's on the approved WIC list. Okay, so, and they give them the app and they teach them how to use it. And they decreased preterm labor in that group of women 30%.
Wow.
Wow. Yeah.
Just by tweaking their diet a little bit. And a big part of it, I think, was reducing the sugar content. But some of these little changes, like the changes in SB 14, the changes to the WIC program via the governor's executive order, I think that those are going to have significant consequences in downstream health. I think they're going to move us in the right direction.
Yeah. And hopefully have a resonating effect across the country as well. And
Yes.
It's good for Louisiana to be known for something really good like SB 14, which was a very good bill, and I had the privilege of testifying for that bill in the legislature. Very happy about that bill. Dr. Coleman, if there are, for our listeners and people who are concerned, who want to express their opinions or their feelings about anything related to public health, experiences that they've had either during COVID or after, what's the best way for them to contact the Surgeon General's office?
Probably just our email that's on the website. It's ralphabraham@la.gov. Wyche Coleman at la.gov. We try to get back to everybody. We've tried to be a source of contact with at LDH. I would not have known how to get a hold of anybody at LDH as someone who's practicing medicine in the state. So we've tried to be a conduit for doctors. So, we get a little hate mail from some of the pediatricians sometimes, but I always try to reply and say at least we're an avenue where they can make contact with somebody within the organization.
Yeah.
If you're looking to invest in physical precious metals or convert your 401k to a precious metals backed IRA, please consider making your investment with our trusted partner, Metal Stacks. Their prices regularly beat the big sites and they have no credit card fees or minimums. Shipping is free for orders over $500. Just visit metalstacks.com/dwalker or get there from our website, freedomstate.us. If you're interested in the IRA conversion, drop me a message at Danielle@freedomstate.us and I can get you connected with their white glove service. Well, Dr. Coleman, I wanted to mention to you, I had a dream the other night. This is very random, but since you were coming on, I wanted to mention it to you. And in this dream, there was a big statewide competition that was happening, and it was a Maha competition across the state of Louisiana at the parish level. So every parish had to come and present like a plan and like what they were doing as a parish to advance the Maha cause in that parish. And some were like building kayak, areas where people could go and do outdoor sports. Some of them were promoting safety in seafood. Anyway, it was this whole big thing. I have no idea. Anyway, it's very funny to have had that as a dream, but I wanted to put that forward to you because I think it could be a really cool thing for our state to maybe usher in some competition amongst the parishes that would be healthy to advance the cause of making Louisiana healthy again.
Well, I love the idea. That would get in some involvement on the parish level. I think it's great.
Kind of random. And you addressed this issue, but I'm sorry, did I cut you off?
No, not at all. Go ahead.
I was just going to say, in the spirit of this scripture reading, I was giggling to myself because one of the questions I wanted to put forward to you was there would be some naysayers if you said that Louisiana was leading the way in making America healthy again. People will laugh at that and they might be right. This is a fat state. This is an unhealthy state. But could you give us some pointers and let us know what do you have to say to the naysayers? I heard about SB 14. Is there anything else going on under the radar that's giving us an edge over some of the other states?
Well, one of the big initiatives we have now is to try to get our data in a usable form. So public health data is pretty problematic, at the national level and at the state level. All states hold this Medicaid data, claims data, pretty close to the vest. And, our systems don't talk to each other. The Medicaid claims data, the links, the vaccine system, the vital records, they're all on separate software systems. And some of this is a result of I won't bore you with the RFP protest that's been going on for like more than a decade, but we need a big software overhaul. And I think that public health data, that it is technically possible to take it, coalesce it onto a unified database where you've got all the information there on all the patients within Medicaid and some with that, some beyond Medicaid, but a big database, like at least half the state. And then you can de-identify it in a HIPAA compliant manner and let it live on basically an open source server so that any researcher, any third party researcher could go download this data and say, what is going on? And I think that if we want to make sure that the policies that are being put in place are actually working, I think that some of them are going to work. Some of them may not work, but we need to be able to change course quickly. And I think that if you would have had an open source database like that during COVID, it would have been a lot more obvious what was really going on.
Right.
And I think that the parties that don't have the interests of the people in mind, they have their own interests in mind, the third party interests, they would like for data to be pretty hard to come by. I view open source data in healthcare the same way that I view free speech on the internet. Look what happened when you opened Twitter up. How much different would the world be if Twitter would have been open during the pandemic? And I think that the same is true with healthcare data. And it doesn't have to be that detailed for a researcher to be able to download it and say, a new medicine's come out for a condition. Is it making that condition better? A new interventions come out at the level of public health. Let's say SB 14. We've implemented this. We're taking these things out of school lunches. Is it helping obesity rates, ADHD rates in kids? I think it's going to, because I think that those are some of the root causes. But the proof's in the pudding. And I think that if we can open source this healthcare data at the state levels and then coalesce that into a national database that exists basically in real time, then we won't have to wait years to figure out whether initiatives that we're implementing are working or not. I think that's how you end up with a lot of programs in public health that do an activity, but they don't contribute all to outcome, and they take a lot of money in the process. So if you could get a more real-time feedback loop, I think that we'll be able to make better policy decisions.
Yeah.
Stick with
Is there
double
any
down
reason
on the things that work and get rid of the things that don't.
Yeah. Is there any reason why any of it should be off limits?
Well, you have the personal level data. You can't just put somebody's name out there and say this is their whole medical history. So you have to go through a process of de-identification, right, where even AI couldn't trace it back to a particular individual. But if a researcher wanted to look at data from the Department of Health, they would go through the Internal Review Board, the IRB, and say, we're going to have a data use agreement. You're not going to share this with other people. You're going to use it for the purpose of whatever research. But they're sort of shooting in the dark because they don't know what they're trying to hone in on when they make this data request. If you have a de-identified version of the data, even if it doesn't have every detail in it, it at least gives them the idea to say, I see a signal here. Now let me make a more specific request for the patient-specific data so that then I can publish on that topic and say, this could be one of the very interesting ones is we have GLP-1s for obesity and diabetes now, and they seem to be very effective, but there's some bad side effects. Some people have pancreatitis, and what's the long-term consequences? We don't really know. Like a very basic question would be, do they reduce end-stage diabetic disease? Do they reduce renal failure, heart attack, strokes, things that diabetics get when their sugar is poorly controlled? Because I do have some diabetics who were terribly out of control. Their A1C, you familiar with hemoglobin A1C? Should be about 6 or 7 in a diabetic, and they may be 13, and they get on one of these medicines, and their A1C goes to 5. Well, that's pretty amazing. So I think it probably has an appropriate use in some people, but then, there's a lot of people using it. I don't know if it's good. I don't know if it's bad. But this would be, if you had open source data, third-party researchers could download that data. They could publish on it. They can debate with each other in the academic sphere and let the chips fall where they may. And you could pretty quickly tell whether like a new intervention like that, whether it's pharmaceutical or a program like some of the Maha agendas, are having the intended effect. And if they don't have the intended effect, you can be done with them. And if they do have the intended effect, you can devote more resources to them and do it in real time because we really don't have a good mechanism to do that at public health. We're making policy decisions in the dark.
Yeah, I love that. I love that. And then we don't have to get entrenched with a mindset for 20 years that's not working.
Exactly, and end up with having to have a political solution. It would be better if you just looked at the data in real time and made the best decision you could. And
Yeah.
if it was open sourced and it was just debated in the public sphere, then I think the truth would come to the top more quickly. And so we're really making a move to unify our database, de-identify as much of it as we can, and open source it to the greatest degree possible. And I think we'll be one of the first states to do that.
I love that. That's
Me
a great
too.
idea.
Let me ask a question going back to what we were talking about earlier, Dr. Coleman. There was a bill in the legislature last year that would have simply said that no doctor can be reprimanded, no doctor can be penalized or retaliated against by any board or agency for prescribing a medication that is FDA approved for an off-label use. Before COVID, if anybody had told me that we would need a law on that issue, I would have said, what are you talking about? Doctors have always had the capacity and the ability to do that. I think the legislation was brought in response to some of the pain and suffering that a lot of physicians went through during COVID, who tried to practice medicine, to try to be innovative, to try to do what they needed to do to help their patients, and they were punished for it. What is your position on legislation that I just talked about? Because it wasn't successful, the bill.
Excuse me, we were disappointed it did not pass. I'm an ophthalmologist. 50% of the medicine I use at least is off label. Steroid eye drops, for example, aren't approved by the FDA for post cataract surgery inflammation control. Neither are antibiotics for infection control. We use them both, all the time. And that is true for almost every drug that is out there. So it is that we're having to have a law
Exactly.
to reinforce this longstanding principle, but it is in direct response to the violation of that principle during COVID, when pharmacies would not dispense. The Walgreens CEO says, we're not dispensing ivermectin, we're not dispensing hydroxychloroquine, and now luckily we had independent pharmacies that saved us. I think that the PBM problem is squeezing the independent pharmacies. Really protect the independent pharmacies, because I think they made the results of the COVID pandemic a lot better for Louisiana than they otherwise would have been. And I was disappointed that law did not pass. At least that's moving up in the list of priorities, things for the legislature to talk about, because I think a lot of them didn't understand this. But
They didn't understand it. They didn't understand it, Dr. Coleman, and I was there, and several of the committee members were saying, what's the point of this? Doctors already have this authority. What's the point of doing this? And the primary doctor who testified in favor of it is that they were not being protected. The right was not being honored during COVID. In fact, it was being trampled upon, and to codify this longstanding principle is extremely important in order to protect physicians. So it's good to know that you support it, and hopefully it will be brought again in the next session, and we can get it passed.
So, and I'm sympathetic to the legislators who said, why are we making a law to solve something that's already longstanding precedent in law? And I agree with them. That's bizarre, but it was violated. So this is a direct response to the violations of that principle that occurred during COVID. Look, I think if a licensed physician writes a valid prescription, that it should be filled. The provisions of those laws that allow a pharmacist to say, we're not going to dispense this, were mainly created to say, if you wrote 10,000 milligrams and you meant to write 100, that there would be a stopgap mechanism for them to say,
sure,
wait, we're not going to just give 10,000. Or in the case of like abortion pills, which is not too much of an issue in Louisiana anymore, if they said, I have a philosophic aversion to filling this, that they'd have the ability to do it, that they'd have the ability to not do it and say, and I'm not going to do that. But just to say, I don't like what you're prescribing, so I'm not going to do it. Let's imagine that we didn't have any independent pharmacies, that all we had was a big box pharmacy, and their CEO said, we're not going to allow them to have any drops after cataract surgery anymore. And I write a prescription for it, and they say, we're not doing it. Well, where does that leave us as a physician?
Yeah.
The pharmacist is now the physician.
Yeah. Last question.
Or the pharmacy CEO, even,
Oh,
I
yeah.
mean,
CEO,
the pharmacist's hands were tied completely by the executive decisions.
who has never and will never treat a patient. They're telling people what they can and can't have, and that's a problem.
Speaking of that very issue, Thomas Presley, then Representative Thomas Presley, was very instrumental in defeating some legislation a couple of years ago that would have allowed any pharmacist to dispense any vaccine to any child, I believe it was age 7 and up, without a patient-specific doctor prescription. There were some protocols built into the bill and so forth, but it was concerning to us that a pharmacist, would have the authority to do that without necessarily knowing a patient's history, any contraindications. What's your position on that issue about whether or not pharmacists should be able to administer vaccines without a doctor's prescription?
Yeah, it may be a bridge too far. I think that it should go back to the doctor-patient relationship for most of these decisions. And look, you've probably called Walgreens, and you can't stay on the line for 1 minute without having them tell you the 20 vaccines you can get all at one time. I don't know if they do proper screening, if they say, does this person have some contraindication? Certainly there's not the setting there. I mean, it seems to me when you go in the pharmacies, they can barely get the prescriptions filled on time. I don't think that they have a lot of time to go sit down with someone and do a proper history.
Great point.
So I think that that's another example. I'm not sure. I don't want to throw stones at the pharmacists. I appreciate the
Absolutely.
what they do, but I think that the corporate policy is sell maximum product. And it's back to that idea of collectivism. We're just going to give it to everybody. Doesn't matter who it is. And we should move back to a more individualized approach. So I'm not saying that a pharmacist couldn't do it if they had the opportunity to sit down and have a visit with someone and understand their individual medical history. But the insurance companies have been paid a bonus for vaccine uptake.
Yeah.
Well, you could send them to Walgreens and let them get a flu shot and you get paid a bonus. Well, that is avoiding the doctor visit where they could have interaction and be screened for diabetes, hypertension, other things that may cause them problems in the future. So it was a missed opportunity. And that's an example of where we're paying for something and it's the opposite of the intended result. We're incentivizing the wrong things and things follow incentive.
Yeah, that makes a lot of sense. Before we let you go, Dr. Coleman, I want to mention to our listeners today that Danielle's individual podcast, For the Love of Freedom, has now moved to Wednesday mornings at 10 a.m. Matt Meck will be on her next show. And next Thursday on the State of Freedom, at our normal time, Treasurer John Fleming will be on to give us his views on the legislative session and also talk about the U.S. Senate race. So you don't want to miss either one of those shows. Dr. Wyche Coleman, what a pleasure, sir, to have you with us today. Thank you for all the work that you're doing. And again, for being focused principally on returning primacy to the doctor-patient relationship without unnecessary bureaucratic or corporate intrusion, which is exactly what we've been talking about here. So your efforts are greatly appreciated.
Thank you, Chris. Thank you, Danielle. I appreciate the time. I like the long form format. I enjoyed it. It was great.
Well, you're welcome back anytime. We want to stay abreast of how things are moving along on the Maha agenda. So we look.
Y'all will have a great talk with the boss man next Tuesday. I'll be tuning in to watch.
Yes, sir.
Perfect.
Thank you, Doc.
Well, thank you.
Thank you.
The State of Freedom is a listener-supported podcast. We're committed to pursuing the truth about policymaking, decisions, and situations in Louisiana and at the national level that stand to impact our freedoms.
Please become a monthly supporter of the State of Freedom at freedomstate.us as we continue to expand the voice of liberty across Louisiana and beyond.
Thanks for joining us today on the State of Freedom. Be sure and check out the show notes for this episode. You can always go there and find the calls to action and resources mentioned in the show, and you can find out more information about our advertisers there as well. If you want to learn more about us or support our work, visit freedomstate.us. To get involved with Louisiana Citizen Advocacy Group, visit lacag.org. We'll see you next time. God bless.